that we hold both items 1 and 2 in case if board member is able to join later, and then we can review the minutes. But I'm gonna hold on items 1 and 2, and then we can look at them next month if needed.
Yeah, we run into some of this same kind of problem with committees and stuff that have small numbers of participants. Is it in the bylaws at all that you can actually vote by majority or whatever through alternative means, i.e. email, et cetera, et cetera?
I am not sure because for FOI reasons, I'm not sure like what we would have to do, but we can certainly look into that and we can consult with the law department. You know, I'm not sure if the vote has to be in public or
Right.
then we publish the vote, or I've never heard of that happening, like for, you know, an official board or commission not voting like in person like this, but I can definitely look into that.
Okay, just thought it might help.
Yeah.
Because you can't go too long without getting those things approved.
Right, okay.
Reviewed and approved, sorry.
All right, thanks, Ken.
Good point.
The third item on the agenda is the director's report. So a few quick updates. We were honored last week by Norwalk Community College with them presenting the Norwalk Health Department with a Distinguished Service Award. And I really want to thank CEO Devonish for that honor and really thank the staff for it, because Darlene Hoffler worked very closely with NCC throughout this pandemic with, you know, several of our staff members also supporting all those efforts, you know, all the team that supports communicable disease control and, you know, all the guidance, you know, Brian and Teresa and Megan, and I mean, so many people are all our contact tracers, Sherry, Tahira, just incredible team we have here, and really honored that NCC was honoring our team. So just want to thank NCC and thank our team here for that amazing honor. I also want to.
Good job.
NCC also honored 60 alum at their ceremony, and one of our employees, Rochelle Felix, is our community health worker. She also was honored as one of their distinguished alums. So I want to thank her as well and congratulate her on that honor. All right, I also wanted to talk about the efficiency study. So we've been working on outlining all the different recommendations that are related to the health department in that efficiency study. And we're coming up with sort of action steps and a work plan and timeframes for when we can accomplish those recommendations. And we're working with Lamond on that, you know, because we're working at it as a whole, you know, for community services. So I just wanted to give you guys a quick update on some of that. One of those recommendations was to review the ordinances related to the Board of Health and the Health Department, and with the new restructuring of the city with the Chief of Community Services, to link back, you know, to the you know, there's the Community Services Ordinance, which links us to that, but we have our own separate ordinances. But one of the things that we've been wanting to do for a while now is to look at all of the ordinances that reference the Health Department and the Board of Health and really modernize them and update them, because there's a lot of, you know, there's been ordinances that haven't been updated in decades, right? So we wanted to take while we're looking at that ordinance, I thought, well, let's take a full comprehensive view of all of them and see where we need to update. And so Aniela has started to really catalog all of them and start taking notes. And we think this is going to be a long process to look at all of them, but we're going to need your help in that too. So I just wanted to let you know that, you know, we're taking that on, and hopefully we'll have your support and assistance in that, because it's going to take some time to do that. So just wanted to give you guys that update. So that's one of the things that we're looking at. One of the other things is, you know, we've been talking about software and IT for a while now, right? It seems like every strategic plan, we're always talking about improving our use of technology. And one of the recommendations was to, you know, really truly move to a web-based program for environmental health services. We've tried to do this in the past. And so we're going to take a new look at the system and figure out, you know, are there better systems out there? That was one of the recommendations. And so you'll see this next month when we talk about performance management in more details, but that's one of the things that, you know, we're trying these efficiency study recommendations, figure out what we're going to be tackling and how we can embed them into our existing plans and strategies, right? So we don't lose sight of it. So, we have our performance management system, which Danielle is going to give an update on that. So we're thinking about that. We're thinking about the strategic plan, which again, we'll talk about more, but just wanted to give you all that update that we're working on that, and wanted to specifically talk about the ordinances because I'm going to need your help with that.
You sit on a statewide group. You were actually chair of that group, I gather, for some. Are you still chair?
I'm president-elect right now, and next month I'll be president.
Okay. So from a statewide point of view, is there a pieces of the software that you guys endorse that you all are using a similar one, at least moving on a statewide basis to something more consistent so you can share data?
So that is a great point. That's something we've been looking at. There isn't a consistent system that's being used statewide that's driven that we're aware of. Megan, I don't know if you have anything to add to that for environmental.
No, I know Aniela had done some work and is doing some work just contacting some other accredited health departments around the country to kind of see what systems they're using, and just using, some of those folks to see what systems maybe we want to look at. And so we started to look at one system, and so we're continuing to kind of see. It's really hard because a lot of systems focus more on permitting, and so there's systems that say that they can do health department inspections, but they're more permitting systems. So it's really hard to find something that fits our needs.
But that is certainly, can you bring up a really great point? That is certainly something we can bring up to the state association and see if there's any traction there to be able to, there are certain things that every health department does, right? We all do food inspections, we all do septic, we all do pools, there will be certain things that are unique to different departments, not everyone does housing, but we can certainly, so like that is kind of tailored to what the code is, but you certainly think you can do I agree, there should be a statewide system that we all can use and kind
I'm
of
surprised that the Department of Health hasn't done something. They're so involved with the state on a data collection basis, that we have the all payer claims database that everybody is by law has to contribute to, including payers and all the rest. So you have this huge database out there and it's missing public health. There's no mandates that you have to provide that level of data in a certain format, et cetera. I wouldn't be surprised. You should probably, once you get to be president, you can put something forward that says, put it in the 5-year plan or something that everybody's got to be compliant within a certain amount of time. It just seems like, to compare the information that we need to make decisions going forward, it certainly would be helpful for you in a capacity as a director to get that done.
Thanks, Ken. I'm taking good notes here. Thank you. Any other questions, comments related to those updates? Thank you. Our next item on the agenda is COVID-19 updates. We have 2 parts to this update today. Brian's going to give an update on the surveillance, and Megan's going to give updates on immunizations and outreach. So Brian, take it away.
All righty. Hey, good morning, everybody.
Morning, Brian.
Let me just pull up the presentation. We'll jump right into it. All right, so it should be coming up, actually. Let me go up one more slide. All right, so just as a reminder, this information data that's presented is, collected at the morning of today, May 24th, 2022, and provisional and subject to change. So kind of the, excuse me, the usual slide here. Let's start on the left-hand side. That's the Johns Hopkins Coronavirus Resource Center. So just kind of the update in relation to the entirety of the pandemic, we have about 526 million plus global confirmed cases, 6.2 million plus global confirmed deaths, about 83 million plus US confirmed cases. And then, again, the big milestone that, the state acknowledged, obviously, by lowering the flags, as well as the city has, as well as other, other states and other kind of municipalities have done. You know, we passed the the million deaths milestone. So, you know, that's at 1 million and 2,377. So, you know, obviously a big deal because this is a million plus deaths just related to the pandemic. Likely this is an underestimate because there still is some caveats in terms of interpreting, you know, if somebody actually died from COVID, if it was detected, especially in the early stages of the pandemic back in 2020, you know, a lot of things were kind of rushed in terms of assessing that, and also limitations in the ability and capacity to do so. So just keeping that in mind, obviously a very somber note. So with that said, at the same time, what is going on more recently in terms of COVID activity for the country, you can see here the CDC Community Levels, which again, as a reminder, is categorized as a 3-tiered system: low, green, medium, yellow, high, orange. And, you know, again, there's different recommendations from the CDC based upon this relative to communities. It's based upon county level, and metrics in 2 ways. One is the case rate that you're experiencing, because then it automatically puts you into 2 different categorizations. And then from there, the metrics that are assessed are essentially relative to hospitalizations related to COVID. So it's the percent or proportion that are COVID patients and staff beds in the hospital, as well as new COVID admissions per 100,000 in the hospital. And those are looking at the metrics for the most recent 7 days relative to the data that the CDC receives. So with that said, when you look at it from that perspective, you can see how the majority of the country is still in the green or low. But then you can kind of see in the Midwest, as you know, pretty obvious, but then also the Northeast, which is much more obvious. You know, we're getting kind of pummeled pretty hard relative to COVID activity. So when we talk about the Northeast, you know, obviously there's Connecticut, there's Massachusetts, New York, Pennsylvania, New Jersey. You got even Vermont and New Hampshire and Maine kind of in that mix as well. And so I think that's an important point just for all of us to kind of understand that, you know, and we'll go into the slides about the proportion of subvariants and what actually is kind of playing into that. But it's kind of, again, just what we were talking about before. It's BA.2.12.1 being the primary driver of that. Also not overlooking Puerto Rico is also in the mix there in terms of those recommendations. And then when we zoom in for the state of Connecticut, you can see how 6 of the 8 counties in Connecticut are in that orange or high. Fortunately, Fairfield County is still in the yellow along with Tolland County, but you know, we'll see in the next slide how close that is for our case. But again, just to give an overall kind of estimation, you know, about 9.21% of the country's in high and about 15% is in medium. Relative to the CDC community levels framework. So now, what does this actually mean? Let's go into greater depth. So especially in relation to Fairfield County, which is obviously the most immediate concern for us. Again, we're in medium yellow. The recommendations per the CDC that's summarized here is stay up to date with COVID-19 vaccines, get tested if you have symptoms, wear a mask if you have symptoms, a positive test or exposure to somebody with COVID-19, wear a mask in public transportation. You may choose to wear a mask at any time as an additional precaution to protect yourself and others. If you're at high risk for severe illness, consider wearing a mask indoors in public and taking additional precautions. So just want to emphasize that. I mean, you know, naturally, you know, orange level or the high level, the recommendations get a little bit stronger, right? The big thing is about masking. So they recommend general masking in indoor public settings, as you can see here with the first bullet point on the table on the right-hand side. So just emphasizing that point. But the thing I want to emphasize relative to Fairfield County, you know, looking at the metrics that factor into this. So again, we need to see if our case rate's above 200. And as you can see here per this data, for Fairfield County, we're at 258.55 relative to that Thursday update from the CDC. So we're past that. You could still enter the yellow and high and orange levels, even with being below 200, but it's a little bit harder in terms of the metrics. Nonetheless, when you're above 200, you have to be above 10 for one of the subsequent metrics that I'm about to read. And you'll kind of see, obviously, where new COVID-19 emissions per 100,000 of the population, it's at 9.9. The week before that, we were at 9.8. So we're right on the cusp of entering that. So it has the potential, as long as those trends hold, which, you know, seems so far to be happening, you know, we might enter that orange level. And so then recommendations definitely change for the general community. But the percent staffed and patient beds in use by patients with confirmed COVID-19 is only at 4.1%. It's not past the 10. So that won't be the metric that really kind of dictates that change there. It's, again, this one in the middle here, new COVID-19 emissions per 100,000. But we're just so close to it. we lucked out in some ways in comparison to some other counties that are much higher in those metrics and consequently are in the high. So again, going back to why this is, it's all about it's a good portion of it in terms of the subvariants that are going around. So as you can see here, in the purple, the darker shades of purple, we have the original strains of COVID Omicron that we've been dealing with back in December, January. Then the pink here, you got BA2, and then obviously the bigger culprit too is BA.2.12.1. And so relative to the CDC, kind of forecasting model in terms of what that situation is, looking at from the time period of May 8th to the 14th, you have about 50.9% being BA2 and 47.5% BA.2.12.1, so almost about 50%. And then if you switch over here to the right-hand side, you can see in the dark red again, that is BA.2.12.1. Biggest proportion is region 2, which includes New York, New Jersey, Puerto Rico, and the U.S. Virgin Islands. New England's, probably third place, not too far behind, because as you can see, the Mid-Atlantic is actually now second place for that. But we're all kind of nestled together. It's really Eastern Seaboard, it's getting hit the most, but you can see parts of the Midwest as well, kind of also experiencing that increase in BA.2.12.1. So just to break it down, BA.2.12.1 is about 73.1% of region 2. Again, that's New York, New Jersey, Puerto Rico, U.S. Virgin Islands. About 47.6% to New England. Again, we tend to mirror probably more region 2 just because of our proximity to New York and New Jersey. So unfortunately, that's why we're also getting hit too, relative, especially this part of Connecticut. So looking at hospitalizations now. So this is for the state of Connecticut, COVID-associated hospitalizations data up to yesterday. You can kind of see where we've been and where we are. This data is looking at it from July 2021 to, again, the data point from yesterday. So we're at 348 COVID-associated hospitalizations. As you can kind of look at the trends here, since even, late March, early April, it's really just been a slow increase, but a steady increase. Jumping around a little bit here and there, because, even with the Friday report from the State Health Department, it was around 354. We're at 348 now, so it may jump around. And but it's still kind of holding steady to some degree. So as you can see, for the big 3 Connecticut counties, they usually have the largest proportion of COVID-associated hospitalizations. We'll start off with Fairfield. It's 86 or 25% of that. Hartford 113 or 32%. Then New Haven County at 105 or about 30% there. So you can kind of see what's going on. This is obviously a much more reliable metric, just because if somebody needs to go to the hospital, well, they're going to have to go. And so they can kind of obviously be factored into those metrics to give us a better idea of what's going on. And also I kind of stuffed a couple things on this slide. Left-hand side here is looking at for the state of Connecticut, but now at the municipal level, for the case rates for the most recent data from the State Health Department. That's reflective of May 1st to the 14th. So Norwalk's at a case rate of 36.8 cases per 100,000. As you can see, pretty much every town and city is in the red, except for some small number of exceptions. This is a map that's very reminiscent of back in the wintertime. In terms of those case numbers. I mean, again, keeping in mind that the state framework has, remained the same. So again, to enter the red, you have to have a case rate of about 15 plus cases per 100,000. So again, that means all those towns and cities are meeting that criteria, including us. So on the right-hand side, I stuffed in just like the top 20 state rankings for the recent COVID case average per 100,000 activity. I think it's just important just for us to get the perspective on what's going on. And it's still kind of reflective of, again, what we were indicating before with the BA.2.12.1 activity. Again, the Northeast is usually ranking the highest. We got Rhode Island at number 1 at 78.38, Connecticut number 2 at 72.75. You even have Hawaii in there, but you got Massachusetts, Delaware, New Jersey, New York, Vermont, New Hampshire. I mean, you got the whole Northeast here. We're all kind of very closely grouped together in that regard. Then in addition to that, you also have Puerto Rico, which you're not seeing here. But Puerto Rico at 142.43. So if you give perspective, it's almost double what we have. And then the U.S. Virgin Islands at 109.86. So when you look at it more from a global perspective, number 1 is Montserrat. When you look at it from the World Health Organization case rates, it's at 325. And so Montserrat, as I've learned, is in the Caribbean. As we were just talking about, Puerto Rico and the U.S. Virgin Islands be very high. That's also the Caribbean area. So it's definitely emphasis, and especially what's scary about it is that's a popular tourist destination even now. So, there's a lot of risk of obviously continued transmission and spread. Then also, who's at the top is, number 4 and 5 from global rankings is Australia at 150.48 and New Zealand at 147.82. And especially New Zealand's been a very good performer relative to COVID throughout the pandemic because they also had the advantage of being a small island. But as you can see, they're getting hit hard. Reason being, predominantly, they're in their winter time. So again, it gives perspective of what we could be in the midst of if it was wintertime for us relative to this uptick. It could have been much more severe, even though it's obviously concerning even now. But imagine how it could have been if this happened during the fall winter time. And so it gives perspective also what to anticipate in the future as the fall winter does loom, as we're enjoying, the late spring, early summer months. So just again, just a reminder about that. But again, this is kind of what's going on. But you'll see as this activity continues forward and BA.2.12.1 continues to kind of propagate throughout the country. This is now obviously making its way to the Midwest, the South, to the West Coast as well. So it's going to kind of make that slow wave that we've seen in the past relative to the pandemic, and then bounce around. So doesn't mean we'll be out of the woods once we even get past this peak. There's still going to be opportunity for transmission, especially those that are going to be naive to COVID for some time, because maybe they didn't get affected this time around this year, but maybe they'll run that risk of exposure, especially as they do more activities, as well as also the vaccine waning. Somebody might be more susceptible to getting reinfected as a result of that, or infected in general, if they haven't been exposed to COVID before. So just something to keep in mind. So then looking back at the municipalities and the big 7 Connecticut cities and their case rates, we have Norwalk at 36.8 per 100,000, percent positivity at 13.3%. Again, data reflective of May 1st to the 14th. The highest is New Haven at 58.5, percent positivity at 8.4%. And then the lowest is Danbury at 20.2 per 100,000 and 11.3% positivity. And so you can see how Norwalk kind of meets in the middle there, so to speak. And again, we're also kind of close to Stanford with, Stanford at 39.6. So, it's kind of reflective of just what's going on with the trends, and especially with the CDC community levels that are also reflective because, New Haven County is definitely in the orange or high. Fairfield County is in that yellow medium, but again, very close to that. And so anything can kind of tip it over. So then looking at it for the entirety, for the city of Norwalk, for the entirety of the pandemic, you have data indicating about 22,862 total cases, 270 total deaths. So the deaths have been holding steady, but again, it's a lagging indicator. It takes time for that data to be processed and brought to the locality's attention. So just keep that in mind. But at the same time, it has been fairly stable. So that also is evident with especially the very high vaccination rates we have compared to other municipalities in the state as well. So again, hats off to all the work that we've been doing, because that's definitely evident here. And then in addition to that, we have it based upon age group proportions for the last 2 calendar weeks. So that's May 8th to the 21st. Not great in the sense that it's a large spectrum of age groups that are kind of leading in regards to this. So we still have the usual suspects, so to speak, in terms of 30 to 39-year-old age group at about 17%. But then you have it pretty much almost tied with 50 to 59 at 14.9%, and then the less than 10 years of age at 14.5%. So then you have the whole spectrum. And the data is a little bit skewed towards technically the older age groups, because you also have even 40, 49 and 60, 65 in the mix here, but then you also have 20, 29. It's almost not that much different. So it's unfortunately this wide age group dispersion is not great to see, because that means there's ample opportunity for infection relative to these different groups and the activities they may engage in different household settings, to subsequently expose each other in some sort of common area and potentially then infect those households and then continue obviously this chain of transmission that we're currently seeing. So not great to see this, because it's not focused, say, solely at one age group, or distinctly in that manner. So again, the name of the game here, as even with the CDC, community level recommendations, the big thing is obviously having testing, but also really vaccination, because that's really going to offset not only the severity of outcomes and hospitalizations and deaths, but also it reduces the risk, the period of somebody that might be experiencing these symptoms too, if they are symptomatic at all. Duration, because they're not experiencing a severe illness, they're able to overcome it quicker. They're less likely, obviously, to transmit because they're not excreting as large of a viral load. So that reduces that risk of transmission there too. So to emphasize that point again, For all ages relative to the newest data, we're at 88.9% for initiated vaccination, 79.55% for fully vaccinated, and 41.68% for additional doses received, which is reflective of booster doses in that regimen. And so for initiated and fully vaccinated, again, the name of the game, the big thing to hit home is the 5 to 11-year-old age group, which just recently got the official approval now outside of the EUA for the vaccine. So that's really great. And so we're going to see, obviously, hopefully more uptake in regards to that, because there might have been some hesitancy. But nonetheless, it's still at 41.2% for fully vaccinated. So that still is an opportunity. And also they had later eligibility too, so just keeping that in mind. But then also for additional doses received, this is obviously the trend that's a lot more concerning for those especially amenable to receiving the vaccine. So we have it for 65 plus 82.2%, which is, it's good to see that number. It's not at the 100%, based on census estimates for fully vaccinated, but it's getting there. But then you have, 57% for 45, 64 years old. So leaves a little bit to desired. And then anybody below the age of 45 years old, for these age groups, in terms of additional dose received, still some to be desired, right? It's not even at the 50th percentile. You got essentially 37% for 25 to 44, 30% for 18 to 24, and about 29% for 12 to 17. So just hitting that point home with the relative to the age groups, and then obviously 5 to 11 being a low uptake, relative to the circumstances that meet the criteria for boosters. But again, it's following a positive slope linear trend. The younger the age group, the higher the gap in terms of uptake for those booster doses, which we're going to need to obviously get out of this unfortunate slump relative to and prolonging of COVID activity because of this new subvariant. But then also we have to really kind of consider that in preparation for the fall winter time. That's definitely where you go hard in the paint, so to speak, in terms of sports terminology, just to make sure everybody is up to date with their vaccines. And the CDC, I know, is updating their definition for that too, so something to keep an eye on. So then flu surveillance, because flu is also in the mix here. And as you can see, you got New Mexico, you got Florida, you got Puerto Rico that are hotspots for flu activity still and flu surveillance. You got even New York, which is technically kind of at that border between moderate and high activity, and Massachusetts in that mix as well. Connecticut, fortunately, is faring a little bit better at low or minimal activity relative to the flu. But again, we're at the whims of kind of surrounding states and the activity that occurs there. So that's something also just to keep an eye on. So flu is still out there, even though with this amazing weather that we've been having, it's not something to overlook, and also in the differential diagnosis process. So with that, again, what tools we have, vaccination being a big part, which is obviously emphasized in the third bullet point, but then we also have testing. Testing, I think, is going to be, again, very important in this whole mix here. So whether it's at-home tests, second bullet point, or the PCR test, wherever somebody might seek that out, but also we have the municipal site that's in conjunction, obviously, the state health department and Quest Diagnostics, and that's again at Lockwood Matthews Mansion in the lower parking lot. 4 days a week, Monday, Tuesday, Thursday, 2 to 5 p.m. and Saturday, 10 a.m. to 2 p.m. Again, very important resources. PCR testing. You can do it from your car, which is really great. And, also this information data does help us to better understand what the current rates and situation is for the pandemic, because we're also, with the at-home tests, things are getting offset a bit. So if you really factor that in and put us back in the early stages of the pandemic when all we had was the PCR test at healthcare facilities, which gave us a much better picture of what was going on, especially for those that are seeking the testing. Right now, it's obviously, our numbers could be double. It could be more. In terms of that as a result, because of these at-home tests that are not reported. But nonetheless, you have the opportunity to report this information to our attention at our local portal. So again, inside this link here, the second bullet point. Again, I want to also emphasize COVID.gov. It's a really important resource. It's a one-stop shop for all things COVID from the federal government. That includes those free at-home tests, those free face masks, especially as we're at the cusp, or if somebody really wants to, wear a mask, by all means, because we're at the medium yellow level. But once we enter the orange level, it's definitely recommended for all indoor public activities that, wearing a mask. So people can get their mask there. They could also do the test to treat locator, which, don't forget, we do have a treatment out for COVID. Again, it's best to do it early in the stages. So getting tested early, so then one can then consequently get that treatment is important. And then also just other kind of resources somebody can find. to help mitigate and prevent further transmission and severe outcomes relative to COVID-19. We also have our biweekly report, which we will be doing this Friday as well. So it's something to see on the city webpage as well as social media. So keep an eye out for that as we do updates for the community. But that is it. Thank you, everybody.
Thank you, Brian. Are there any questions about Brian's update?
Always a whirlwind of activity and information.
Thank you, Ken.
It's excellent, and all the graphs and all that additional information is really helpful. Thank you.
Thank you.
All right, great. Thanks, Brian. Still so excited that Brian's a member of our team and we've got our epidemiologist.
Brian, how much of that data are you crunching versus just becomes available from the department statewide?
So it's a mixture. I'm pulling from a lot of different resources. So I'm pulling from the CDC, from the State Health Department, from Johns Hopkins University, as well as the crunching that I do relative to data that's, confidential data because it's line list data. It has patient information, things like that. And so that's like with the age group proportions, other kind of trends as well. But it's a mixture. And then, the reason why I do this presentation in this manner is because it's all over the place in regards to that. I mean, you can access the COVID reports from the state, but then it's very technical and it's not going to be easy to convey to the layperson. So I'm hoping trying to, with these presentations, meet that middle ground. For those that may be more interested in the more technical details, I provide that, but also at the same time, provide these visuals and simplified visuals to make it easier to convey that message that, we're experiencing an uptick in COVID activity. It's been going on for quite a few weeks. We really want to offset that severe outcomes as well as just mitigate this transmission so we can enjoy the summer as best we can. But it's a mixture.
Yeah, I just think it's such good information. I'm wondering how do you get that out? I mean, it's great that we get to see that, and it's wonderful. I can walk around now with a lot of stats in my head, or at least know what trends are happening. Is that something that the Common Council would benefit from, of just seeing this presentation once? Just to know that is what's out there and available to the. Not that it's just you're not going to send this out to everybody all the time, but educating our leadership in the city. This seems to be a great tool. I don't know if others feel the same way or.
And so actually, I'm glad you brought that up. So Brian has been presenting to the Common Council. So now it's the Community Services Committee. So he's been presenting once a month. That's what we're part of. And previously we had been part of the Health and Public Safety Committee. And so that is something that the council has been very interested in hearing those updates. So it's been great.
Great.
And then along with that, I put up the slide about the biweekly report. So pretty much everything I'm presenting here, it's summarized or visualized inside that report, along with the mayor's commentary. And so I also recommend everybody check out. And obviously more pertinent updates come through the social media, along with just everybody's just a quick alert that the new report's out. So that is also another resource that we provide to the community to give this information at their fingertips and the visuals tied to it.
Thank you.
All right. Thank you, Brian. And now I'm going to pass it on to Megan to give an update on immunizations and outreach.
All right, so I'm sharing my screen. I only have 5 slides, so not as much as Brian. Let me just see. There we go. So I'm going to be presenting today on the COVID Immunization Action Plan, also known as CAP. You may be familiar with the IAP program that Pam based overseas. And so this is part of that program, but really just focusing on the COVID immunization. So the goal of this program is to increase COVID immunization access coverage through outreach, education, engagement of community members, providers, and other key stakeholders, with a strong focus on vaccine health equity. And so this program is a newer program to our department. Some of our community health workers, which you see the picture of them in the center, they started in January and February. So, we were onboarding them. And so today's presentation is really just going to be talking about the first quarter of all the work that they've been doing. And so we have Rochelle, Jake, and Ellie, who are our community health workers, and we're still awaiting a 4th community health worker, which we're posting for And similar to IEP, we have the same coverage area. So all the way to the right is a map of the coverage. And so it's not just Norwalk, it's Norwalk and the surrounding towns. So Richfield, Weston, Westport, and Wilton, as well as New Canaan, and then Danbury we cover as well as Newtown and Brookfield. And so we have a pretty large catchment area. Again, this is the same region that we cover for traditional IEP. So a big focus area for us to do outreach on. And so just some of the outreach that we were able to, do within that first quarter. We did a lot of community building, so a lot of partnerships we started to build, just introducing this new program, what our focus was. And so right here is just one of the presentations that we did at the Carver Center, where we had a table and we were available to answer questions to parents and students as they were coming in and out. And then the picture all the way to the right was at the Norwalk Community College, where we had a Jeopardy game and a Kahoot game. And so it was a really interactive session in their cafeteria. So people were able to come up and, learn information about the COVID vaccine or have any questions answered that they may have. We also partner very closely with Family and Children's Agency. They also have community health workers, which also focus a lot on COVID. And so we partner almost on all of our events and outreach with them. So it's a really nice big team. And then below are some of the bullets of some places that we've gone in the last quarter. So the Carver Community Center, like I mentioned before, the bridge in South Norwalk where the day laborers wait, NCC, Person to Person, Open Door Shelter, Brookside Elementary School, and then just a lot of general canvassing, which probably in a future meeting will show you guys some maps that Brian has helped us create with the GIS person from the city. And we'll kind of be able to show you some of the canvassing that we've done in Norwalk and as well as the region that we cover. And again, just mentioning a large partnership with FCA, Family and Children's Agency, and the Norwalk Community Health Center. We've been able to partner a lot with them. And then here's just a few examples of some community educational materials that we've shared. Some of them we've made. We also have a lot of items that we use from the CDC. These are more we're able to link them directly to our website. But some facts about COVID and the vaccine, the smart cards, which is once you get vaccinated, you're able to get your vaccine information on your phone. So if you're traveling somewhere, you're able just to show them your vaccine card on your phone. So we always promote that around the community and show people how to use that. Supporting your immune system, just overall good health. We also talk a lot about mask wearing, how to, proper wearing of masks. We always have masks with us that we usually are able to hand out. And all these materials are usually translated in English, Spanish, and Haitian Creole, which are the most popular languages spoken in our community. And then here, I'm not going to read through all of these, but these are some of the highlights that DPH, the state, gave us back on our quarterly report. That we served 10 plus tables, community events. We were able to reach an estimate of 470 people individually. We were at 50 plus locations within the community. We met with a lot of medical community partners just to tell them about the CAPS program and discuss ways that we could partnership in the future. A lot of social media traction we had, this quarter. And then our work around health equity. So like I mentioned, Brian, these presentations that he just gave you guys, he gives similar presentations, but really focused on the vaccine coverage in our region. Every other week, he's meeting with our CAP team and he's reviewing that data with our community health workers and myself. And then we're able to take that data and kind of determine what kind of outreach we want to take based on the data. So our work is, really looking at the data and let that drive our work. As well as our material being translated into multiple languages. 2 of our community health workers are bilingual in Spanish, so that is a great support to our community. And really trying to increase our partnerships with our faith-based communities, as they are our trusted messengers. And so That's all I have, but this is just a reminder of, we were onboarding all of our staff in January. And so this is work that just happened in those quick few months when they were still getting onboarded. This is a brand new program, so they're building a lot of things. And so it was really amazing when I was putting this report together to the state to see all the great work that we were able to achieve in such a short period of time. And so next quarter, if I'm able to present again to you guys, I'm sure, we're just gonna have so much more to share with you. That's all I have. Any questions?
No questions, but excellent work. We come to these meetings every month and look at all the work that you folks are doing. It's pretty amazing when you look at it all. So good job.
Thank you.
Thank you, Terry. Great job, Megan. You and the team are doing really great work. Okay, so the next item of the agenda is a strategic planning update. I know we're getting close to the end of the meeting, but I just wanted to let you all know that we're looking at updating our strategic plan, and we're going to need your help and support in that. So we'll send you information about, we're going to have 1 or 2 Board of Health members participating with staff with sessions looking at updating our plan. And we'll present an update next month on where we are with the strategic plan. But I wanted to reflect back on, where our plan was, our past plan, and how much we have accomplished. So give me 1 second.
What kind of time frame was our last plan? Is that part of this? Is it
Yes. So
things are changing so incredibly fast that trying to put out, 3 and 5 year plans is kind of moot.
Yeah, so I would love your take on that. So our previous plan, can you guys see my screen, the value statements, our vision, mission, all that? Okay. So great question, Ken. So our previous plan, we had developed it, I believe, at the end of 2016, and we started in 2017. And we would put together a work plan for 2 years, and then we ended up extending it out for 1 more year, additional year. So it was a 3-year plan, but we originally developed it for 2 years, and then we updated and changed it to make it for 3 years. And so I was thinking this, when we're developing this plan, kind of similar situation where we plan out for the next 2 years, and then we can adjust. Honestly, we can adjust it every year, and I think we're going to adjust it more frequently. But that was what I was thinking, is we would do a 2-year plan, because like you're saying, Ken, so much can change. Everything evolves so quickly. Does that sound like a good idea?
Yeah, I think that makes sense. Yeah.
Okay. Because I know typically, strategic plans are 5 years, but we've always done them a lot shorter than that. We've done year, 2 year, 3 year. But so just to recap where we were looking at public health leadership, adapting to changes in public health practice, workforce capacity and development, and communications and community awareness. And so we had looked at, all the discussions that were going on at the time. Remember, there was talk about public health regionalization. We were talking about chronic disease management programs. We're talking about emerging outbreaks, not knowing what was coming down in the future. We're talking about FDA model food code. So we kept track of a lot of the different disease trends, and we pivoted and we worked to address them. There were a lot of change, remember we had the Health Enhancement Communities Initiative where we worked, that was part of that SIM grant. We worked at all the different trainings related to the food code. We implemented chronic disease management programs. We worked on insurance billing, and now we have a part-time medical biller. We tracked national and state budgets very closely. We've had some changes, within the WIC program and the IAP program. We made some changes in our sexual health clinic where we've implemented PrEP and expedited partner therapy. We've really transformed the health department in a lot of ways by adding new staff and updating existing staff job descriptions. We've, created new divisions, community health, and now we're going to have the epidemiology division. And so I think it's something that this department has always done, is we've always had an eye on what's going on, across the state and nationally. And we have the Board of Health to thank for a lot of that too. You guys always have a good idea of what's coming up, and you have a good pulse of, you know, what's going on. So thank you for that, and continuing to push us to be aware of all of that. You know, one of our main focus has always been on maintaining our core functions, of course. So while we're thinking about all the changes and moving forward, maintaining our core functions as well. And then maintaining FAB accreditation was also a big part of that. And so we achieved that this year, and we kept at it, you know, throughout the pandemic. We put a little pause, but we continue to do that work, and continue to maintain our essential plans, and as well as our policies and procedures. You see that mentioned. And then our second goal was maximizing the capacity of staff and volunteers. And so we did a lot of staff training on what was going on in the different divisions. We held staff meetings, and we gave updates. We did some shadowing of coworkers. We've done so much professional development. I think it's something that's one of our values, right, is workforce development, and that's embedded within the accreditation program in our, I would say, our workforce development plan. We mentioned utilizing technology, and I think that's something we have to continue to push towards and make improvements. We've done certain things like utilizing Canva in our design work, Hootsuite to assist with social media. We have all the different state supported systems that we've been using throughout the pandemic. Brian has brought skills in ArcGIS and Power BI, and he's been utilizing that in his work. And so our capacity, talking about, you know, adapting to changes. I mean, I think this pandemic is a really great example of that. I think we have been very flexible and adapted as needed, you know, based on community need. And then look at this development, utilize a volunteer base. Well, it's a good thing that we had this in our strategic plan many years ago, because we relied on our emergency response team so much for our response. They were essential, you know, both on our, you know, within the health department and the city side. So just amazing thinking about, you know, where we were and how far we've come, and how many volunteers have supported us, and all the monthly meetings that Donna and Glenn organize, all the trainings really was integral and where we were at the beginning, you know, to be able to respond as we did and to vaccinate as many people as we did. So, and then the last part is communications. I mean, we've done a lot related to that too. Social media, sending out the press releases, thinking about all the different media coverage we had throughout the pandemic. But, you know, we had other things like EEE. We've had coverage related to lead poisoning prevention, flu, hepatitis C, our relocation program. Our social media increases, as looking back in November 2018, we had 493 Facebook likes, and now we have 2,500. So we've certainly grown and expand related to our outreach work. We've done a lot of trainings related to customer satisfaction. We even organized and coordinated a training for all city staff related to de-escalation. We survey at least one customer group per year. So I just wanted to highlight that. And I also have this summarized in a report, so I can send that all to you so you can look at that. But so as we move forward and think about where we're going to be, you know, with our next strategic plan, it's always good to look back and what we've accomplished. And really, I'm really proud of our department for how much we don't let this plan just sit on a shelf, right? We really look at it, supervisors look at it, and as we update this next plan, we'll continue to do that. It'll be a living document, and we'll strive to keep meeting our goals and objectives. Anything anybody wants to say about strategic planning? All right, so we'll go.
It is a good idea to look backwards, look back on what has been accomplished, because you do forget that routinely. We all do. So I think that it's good to start as a base. Is, you know, here's the basic function, and we're just building on top of that continuously. So it's well thought out, and hindsight is really, really cool.
Thanks, Ken. All right, so we're going to aim for a 2-year plan initially, and then we can update and revise as needed. But I think that's a good start, because you're right, Ken, so much has changed so quickly. And so we'll probably, even if we put a 5-year plan, we're definitely going to be ended up changing it anyway. So
I was going to say, would that be the 2-year plan? Would that be 23, 24, or?
Yep, so we could do, so we can do, I see us starting this and we can finalize it over the summer, I'm thinking. So maybe around fall time, we adopt it. So then, yeah, 2022 to 2024. So maybe, yeah, it might end up being like January 2023 through
Yeah.
December. Yep. All right, sounds good. All right, Aniela's going to give an update on performance management.
Good morning, everybody. So Megan and I have been working with all the different divisions, supervisors of each division, and other staff from each of those divisions to update dashboards for performance management. And really the goal here, as you know, is to measure activities to ensure that we are, keeping up with sort of the goals that we set for ourselves, and also to ensure that things aren't really falling through the cracks. There are no issues with the systems that we have in place. So the focus this year for Megan and I has been to update the dashboards to really include activities that are not just supervisory and are not just department centric, but also to reflect roles such as reception, sanitarians roles, housing roles. All of the different employees here do different activities, and so it's important to measure those accordingly and to make sure that we're not just focusing on supervisors' work. So right now we have the administration dashboard, the community health dashboard is pretty ready. Emergency preparedness is looking good. Environmental health looking good. Preventable disease is also looking good. And new to the table is epidemiology and informatics dashboard, which includes a lot of Brian's measures, all of Brian's measures that he's come up with so far. So I'm excited to present those to you next month.
Thank you, Aniela. Anything to add, Megan?
I just want to thank Daniela, for really taking the lead in performance management and just really driving, all of our supervisors and myself and all of our staff to really get these dashboards in good looking shape. She's made some great improvements to the system. And so I'm really looking forward to you guys reviewing those systems. I think you'll be really impressed and really excited for us to, start using them, this coming fall, I guess, or in a couple months, basically.
Thanks, Megan.
Thank you, Aniela.
Yes, thank you, Aniela, for leading the charge, and Megan for all your support and all the supervisors for working on that. So we just wanted to let you all know that next month we will be presenting those dashboards to you all and looking for your input and feedback on them. But staff have been working really hard on them past few months. Any questions related to performance management? All right. I'm going to hold on the policies and procedures for next month. We can vote on them next month, and we'll review all the different changes. But our last item on the, unless anybody has anything they want to mention about the policies and procedures.
No, I do like the summary fashion that you put together. So I started reading this and I realized that I had a place I could go and get a quick summary. That was nice.
Thank you, Ken. We can thank Aniela for that. She put that together for us. Okay, our last item on the agenda is public participation, and I see we do have a hand raised. Good morning, Diane. You can unmute and speak.
Good morning, Deanna Diamore and the board. I just, unfortunately, there was some technical difficulty on, I think, the city's end, so I missed the ending of Brian's presentation. So I will hold off on my thoughts about COVID and messaging, which is still a continued concern. I am so happy. I know that a lot of good changes have been made in this department since your predecessor, and that is to be commended. I wanted to ask that the Board of Health and Deanna, that you consider having public listening sessions, since of course we know public health, the word itself of course is so obvious, in your strategic plan update. Because for whatever reason, the board still does not have their meetings at times when most of the public can listen to all of your very important work, all the things you're doing. Even if that were the case, the strategic plan, and I do think it's very wise to shorten the span. That was a great suggestion, and I'm glad, Deanna, you thought of it and others thought of it. Can we have at least one public listening session with adequate advance notice, and have it, of course, in the evening, early evening, or even a Saturday, where an all of government approach to advertising for you, including our city council members, about just weighing in on the strategic plan before you finish your draft. I think that would mean a lot. I think you'd get a lot out of it. Not only from people like me who have some role professionally in some of what you do, but also the public, and it would help take the temperature of whether the communications and some of the things that you tell us about here are hitting home with the public. So I just want to stress the public side of public health, and that would be terrific. And lastly, how can I see a copy of past strategic plans? And you don't, maybe someone could email it to me, or I tried finding it online and I just wasn't able to go through the city website successfully. Sometimes it's been hard on the city side, on IT, to find things. So anyway, I appreciate you all. And if someone could at least answer the question of, can we have the public included, the lay public, or even I'm not asking for focus groups and things like that, but 1 to 2 listening sessions before you finalize your draft on the strategic plan. Thank you.
Thank you, Diane. We're finalizing our format for everything, but we are going to be giving an update next month, which will be an evening meeting in June. We're going to be talking about the strategic plan. And I'll bring up a great point, because we're also working on the community health assessment as well at the same time, and working out the whole community engagement strategy related to that. And as you all know, the community health assessment and all the feedback that we get from the community on that end also informs our strategic plan. But I will follow up, and I also will send you a copy of our past strategic plans. All right. Anything else the board wants to talk about before we wrap up?
Just a follow up to Diane's question, I believe we made every other meeting in the evening to help accommodate that.
Yep. So thanks, Terry. Yep. So on a quarterly basis, having evening meetings. And so the June meeting will be in the evening. So next month's meeting will be, and that's particularly why I wanted to talk about strategic planning in more detail next month, knowing that it's at a time that might be more convenient for the public. All right. Thank you, everyone. It's 9:06, so we can adjourn the meeting.